I hope everyone has enjoyed the OHDSI 2021 symposium. I trust that you've learned from the advances in data standards, methodologic research, open source development, and clinical evidence that was presented from across our community. I hope you are coming away with lots of new ideas to bring back home with you. I also hope that you've took the time to network with each other, and I look forward to seeing the future collaborations that come out of this time we've all spent together. As this symposium has demonstrated, OHDSI has done tremendously important work over the past year. We all have a lot to be proud of in terms of the scientific innovations we have delivered and the clinical impact that we've made with the reliable evidence that we've produced. But to close this symposium, I wanted to highlight what I'm most proud of this year. It's something that many of you played an important role to make possible, even though none of you likely know the impact that you've made. And it's also something that I hope provides a clear perspective of where we've been, why we're here, and what we can do together as a community. Jamie Weaver has been one of the leaders of our OHDSI community for many years. Those of you know Weaves know that he's a brilliant epidemiologist and statistician. He can hack our code with the best of them, and he consistently goes out of his way to help teach and support others in the community. He's a real titan in every sense of the word, and I'm honored to call him a colleague and friend. And I'd like to have him share his story.
Hi, I'm Jamie Weaver, and I'm an epidemiologist at Janssen R&D, and I've been an OHDSI collaborator for 6 years now, and I've worked with many of you. I'm an empiricist, and I believe that knowledge comes from observation and what you can infer from it. By systematically assessing sets of observations, we can draw inferences about the underlying data generating process that may be generalizable, and we casually call these inferences evidence, and we can use them to support all manner of application. I don't know how many of you get regularly tangled up in epistemology and philosophy of science, but I'm quite certain that all of us spend a considerable amount of time in the deep weeds of the scientific and technical processes of generating reliable evidence from healthcare observational data. While doing this, it's easy to forget that these empirical observations that we rely so heavily on are people, each one of them consisting of their perfectly unique set of experiences, characteristics, and qualities that define who they are. And I'm drawn to this type of research because I'm so captivated by this human diversity that's captured, however incompletely, in real-world data. But rather than speak about research and objectivity like usual, instead, I'm going to speak to you today about my being a patient and my subjective experience with cancer and how real-world evidence has really helped me with an important decision. I spent the summer of 2020 with gradually worsening back pain. Since it wasn't improving with physiotherapy, later that fall, my sports medicine doctor ordered an x-ray, both of us expecting to find muscle, ligament, or bone injury from my insistence that I can still play basketball like a teenager. But instead, the x-ray revealed several masses in my lungs. As quickly as she could, my doctor scheduled me a CT scan at the local cancer clinic, where they would be able to see me in 3 weeks. But being properly scared and very uncomfortable waiting this long, and with increasing back pain, I chose to present the next day at the emergency department at a hospital near where I live in downtown Toronto. So I explained my situation to the emergency room doc, who promptly ordered me a CT and MRI. Within a few hours, this doctor and the radiologist on call reported that I had extensive metastatic disease with lesions in my lungs, liver, pelvis, and spine. My back pain was from vertebral compression fractures and nerve compression, and I was extremely lucky that my spinal cord wasn't compressed. It was very close, and immediate surgery had been suggested until a larger team had reviewed my MRI. We thought it was melanoma, considering that I'd had a stage 1A mole removed back in 2017. My sentinel node biopsy was negative, and in retrospect, I was terribly overconfident in that result. I suppose I shouldn't have been surprised by this new diagnosis, given my history and knowing that diagnostic tests regularly return false negatives, but I was still shocked. So that day, the ED doc made my referral to Princess Margaret Cancer Center, also in Toronto. It turned out I could be seen and assessed in a week, so I went home with some painkillers. During that week, between my ED visit and my appointment at Princess Margaret, my health deteriorated considerably. The pain in my back was steadily increasing. It was now radiating elsewhere, and I was unable to sleep. It was quickly becoming totally unbearable. So when I got to my appointment at Princess Margaret, they took one look at me and immediately checked me in, and I stayed for a week. I was stabilized, got my pain under control, and had more imaging done and a biopsy and molecular test that indeed confirmed BRAF mutation positive melanoma. I got to know my medical oncologist a little bit, and we discussed his recommended treatment strategy at length. In collaboration with the radiation and surgical oncology teams, we first ruled out surgery and then decided on a course of radiation for my spine. Lastly, and based on the evidence from an ongoing trial comparing the sequential combinations of targeted therapy and immunotherapies for melanoma, I initiated dabrafenib trametinib targeted therapy for 8 weeks and would then switch to ipilimumab nivolumab, or ipi-nivo, which are both immunomodulating monoclonal antibodies. I've spent a great deal of time considering inclusion and exclusion criteria in trials and observational studies, but this was certainly the first time that I was reviewing these criteria to assess whether I met them. The question was really, how much does evidence from this trial actually apply to me? These treatments got underway in early November. The targeted therapy ended up lasting about 10 weeks because of a few breaks needed for fever to pass, which is a known side effect. I was fatigued and was with too little energy to really effectively participate in my family, social, or professional life. I relied on others more than I ever had, and I felt extremely sad for my kids. It was really not a great time. Before switching treatments, my care team recommended another round of radiation for my spine in case the time from immunotherapy initiation to its beneficial effect took a little while. So we did this, and then it was mid-February by the time I started combination ipi-nivo immunotherapy. It got off to a rocky start. I pretty quickly developed pneumonitis, and it was unclear if this was attributable to radiation, immunotherapy, or both. Regardless, we treated this with steroids, which I took for 3 weeks and tapered to a low dose before resuming immunotherapy, this time Nivo monotherapy. Everything seemed okay and improving at this point until my MRI in early May that now showed brain metastases with bleeding. I had one 4-centimeter lesion on the right side parieto-occipital region and about 10 smaller lesions elsewhere. Almost immediately after getting this news, I began to experience the associated neurological deficit. At first, I was a little unsteady on my feet. I veered a little to the left when I walked. Then it became difficult to type with my left thumb on my phone, then with my entire hand on a keyboard. And eventually I started getting surprised with the presence of my left hand altogether because I was clearly failing to properly register where it was in space relative to the rest of me. On May 10th, I underwent a craniotomy procedure to resect the large tumor. This procedure was performed without complication, thankfully. Recovery was no fun, and it was made worse by the pandemic visitation rule of 1 visitor for a maximum of 3 hours per week. These hospitals are truly amazing places. They're the pinnacles of medical sciences, where major neurosurgical procedures like these are routine. But hospitals are not great places to heal. I was in some terribly dark places during my 9 days of recovery, and at times I was really tested with what I thought were the limits of what I could endure. It was also in this time that I received a huge outpouring of love through every electronic channel conceivable, which really helped me get through this. So I was slowly but steadily recovering from surgery, but by now I'd been off immunotherapy for almost 2 months, and my doctor was anxious for me to resume. This presented some tension. It was possible that the ipilimumab was working in that it had shrunk the tumor, but was also harmful in that it may have caused the bleeding and inflammation. Until this point, my doctor had supported every treatment decision he recommended with evidence-based rationale, and I'd actively participated in deciding which approach may offer a better benefit-risk profile. But unlike these previous decisions, evidence to support this next step was sparse. But it didn't matter because considering my disease progression, I had to continue therapy and I had to make a treatment choice immediately with substantial implications for me and everybody in my life. So the decision that I now faced, was whether to resume immunotherapy as combination ipi-nivo or nivo monotherapy. This represented a pretty clear benefit-risk trade-off, but there was uncertainty about the benefit with speculation that combo ipi-nivo might be better. But there was also uncertainty in the risk with the concern that combo ipi-nivo might increase the risk of more intralesional swelling or hemorrhage that would require neurosurgery to correct. I did know with certainty that I'd had neurosurgery already and did not want to go through it again. Evidence from landmark clinical trials has provided a really strong evidentiary basis for first-line immunotherapy in newly diagnosed melanoma patients. But since my clinical history was drastically unlike the patients in these trials, that trial evidence was really less applicable to me. So, as an epidemiologist at a large pharma company and member of the OHDSI community, I also have unique access to the tools and resources to rapidly create real-world evidence. So I decided to generate some to add an additional piece of information to support this decision. And of course, the indefatigable Patrick Ryan helped me. Okay, so here's what we did. Our initial goal was to try to find patients as similar to me as possible. So we entered my entire recent clinical history into an Atlas cohort. And this was a fun exercise, but we, of course, and as expected, we found 0 patients. But after much iteration, relaxing many restrictions and redoing concept sets, all the cohort building activities, we were able to eventually find patients that still looked somewhat like me. We landed on the following definition for the general population. This was males aged 30 to 50 years at first occurrence of stereotactic radiosurgery of the brain. And then we restricted them to those with metastatic melanoma anytime prior, brain metastases in the last year, and a craniotomy procedure in the last year. And then lastly, we required a nivolumab and ipilimumab exposure both before and after the stereotactic radiosurgery index date. This returned us 12 patients from 2 large US claims databases. So we reviewed these patient profiles, and on the screen you can see one of them here. The horizontal y-axis shows us time relative to the index date, which was stereotactic radiosurgery of the brain. 3.5 years ago, this patient had a melanoma diagnosis and a sentinel node biopsy. 4.5 months before this index date, their situation deteriorated. They had a cerebral hemorrhage, which likely then identified the secondary metastases in the brain, lungs, and GI system, and prompted the craniotomy for resecting a brain tumor. Shortly thereafter, this patient initiated ipilimumab nivolumab combination therapy, followed by nivolumab monotherapy. Interestingly, this patient took nivolumab monotherapy after their stereotactic radiosurgery, which was one of my options. This patient's clinical history looked pretty remarkably similar to mine, but with so few patients, we relaxed the prior craniotomy and SRS requirement to produce a cohort that still resembled the intent, but was of a larger sample size that could produce more reliable aggregate statistics. It was from this population that we created 2 exposure cohorts for use in a comparative population level effect estimation framework. There was the ipilimumab nivolumab combination therapy cohort that was indexed at first exposure to nivo with an ipi exposure observed between 7 days before and 7 days after the nivo exposure. The nivo monotherapy cohort, exposure cohort, was indexed at first exposure to nivolumab with no epi exposure observed between 7 days before and 7 days after the nivo exposure. This returned us 25 and 35 patients respectively. We assessed the baseline characteristics of the ipi-nivo and nivo exposure cohorts in terms of index year month, condition occurrences, procedure occurrences, drug exposures, all during the year before index. The idea is that if we were to see cohort similarity at baseline, it may allow us to make the cautious inference that any differences in procedure and condition occurrences during the year post-index may be attributable to the ipilimumab exposure and not observed confounders. So then we compared the 1 year post-exposure characteristics of the IPI-NIVO and NIVO cohorts in terms of observation time, condition, and procedure occurrences. And these conditions and procedures were intended to represent proxies for safety outcomes. And the observation time was meant to represent an extremely crude proxy for survival, since patients can exit the database at death. So here we see that on the x-axis, this shows covariate prevalence for the IPI-NIVO cohort, and on the y-axis, the same prevalences for the nivolumab monotherapy cohort. The left panel shows this information in the year before exposure, and the right panel shows this information in the year after. At baseline, we see that the conditions and procedures are evenly distributed about the diagonal, showing that there are few observed characteristic differences between these groups. Importantly, they were well balanced on baseline covariates that included cranial inflammation and hemorrhage and prior targeted therapies, which are both plausible confounders of the relationship between immunotherapy choice and subsequent cranial complications that I'm so concerned about. In the year forward, what we see is that the conditions and procedures were predominantly below the diagonal, indicating a greater prevalence in the IPI-NIVO cohort. We observed craniotomy procedures slightly more frequently in the IPI-NIVO cohort, but importantly, cerebral infarction and cerebral hemorrhage were approximately twice as common in the IPI-NIVO patients. Lastly, the nivolumab patients had longer post-exposure observation time, which might suggest an association with increased survival. This exercise is obviously subject to condition and procedure misclassification and residual confounding. But given the decision-related time constraint and that we observed similar results in 2 large data sources, and that the findings were aligned with a hypothesis from the literature, I felt that this was a reasonable piece of information to use to support this decision. This evidence obviously is not going to be good enough for a publication. It's definitely not going to JAMA, but it was an extremely useful evidence for this situation that I was faced with. So ultimately, I resumed NIVO monotherapy, and I'm still on it and feeling well. So far, my outcomes have been good. I've bucketed them as health, as in health. My energy and strength is increasing. I'm gaining weight, and I haven't had any subsequent neurosurgery, which makes me very happy. I can participate in most of the important areas of my life again, like with my family and my friends and my professional colleagues. I can horse around with my kids. I can see and enjoy my friends, and I'm back at work and finally going to start that doctoral program that I've been hoping to start for years. This journey was really made extraordinarily easier by a brilliant and dedicated oncologist and other care providers, the immense support from my family, friends, and colleagues, and it was this support that allowed me to focus completely on my health. And it was, in many ways, my initial distress that was total was replaced with a profound gratitude. I know that my journey isn't over, nor will it ever be, but it's been really improved by this exercise and this experience. This exercise in personalized real-world evidence generated at point in care was an interesting one. The real-world evidence was personalized in that it leveraged information from cohorts of patients designed to reflect me and the specific decision at hand. And it was point in care insofar as that we generated it over a 36-hour period between when the decision requirement became apparent and when treatment continuation had to happen. So really, OHDSI community, this was your tireless work in data standards and methodological research and open source development that facilitated it. So as sincerely as possible, I thank you endlessly. What I really hope you'll remember from this is less about me and more about this really special research enterprise, and specifically that OHDSI's mission is to generate reliable, actionable evidence for patients. But patients isn't some obscure, ambiguous them, but it's also very much for us, which includes you and me and our families, closest loved ones, and everyone else we know. But by speaking a little bit about myself, my intent's really to remind us that behind every single one of these hundreds of millions of patient IDs is another story like mine, full of every up and down you can imagine, and each story perfectly unique.
Our world has 7.9 billion people right now. That's 7.9 billion lives, 7.9 billion stories, all of which at some point will be in the role of a patient. That includes you, your parents, your children, your friends, your neighbors, everyone in our community. Now, George told you that our OHDSI data network is now comprised of more than 330 databases, collectively covering more than 800 million unique patient records, representing more than 10% of the world's population. And Jamie just told you his story. Now, the incidence of malignant melanoma is about 3 per 100,000 persons. And the incidence of brain metastases and advanced melanoma is about 45%. So if we do the math, that means that there's more than 100,000 patients each year who are diagnosed with malignant melanoma and discover brain mets. And more than 10,000 of them could be in our data network. We can see a few hundred each year in CCAE alone, more than half of which are men, but less than 10% are under 45. So we shouldn't get too excited in the statistical power of a cohort sample size, and we mustn't lose perspective of what these data represent. Each of these patients have their own story, just like Jamie has his. None of them are the same. The data we have can help tell those stories. It's our job to listen to the story that the data is telling us, to learn from the experiences of the patients of the past. We need to develop analytic procedures that extract the stories from the data, find the patterns in the stories, and use those patterns to better understand the real-world experiences of patients with disease, to examine the safety and effectiveness of medical interventions, and to predict health outcomes for patients wondering what will happen to me. Our job is to help write a new story for the patients of the future. We need to take this on together, not as an opportunity, but as an obligation. And we have to do this with the same urgency that we've brought to all of the other research we've done, because patients like Jamie are waiting. I remember vividly my palpable feeling of excitement the first time Nigam Shah shared with me his ideas about the green button and his vision for an informatics consult. And I've been thoroughly energized each time I've visited the team at Stanford and read the publications by Allison and Sarab to see their progress. I'm so proud of Anna Ostropovitz for leading the effort to pilot a data consult service within Columbia University's Irving Medical Center. But I'm also troubled that these are largely exceptions to the rule, that they've resulted in some nice scholarships in a few high-profile journals, but they haven't really resulted in legitimate part of clinical care. I'm bothered that thousands of patients like Jamie are facing important decisions each and every day, many of which could be informed by better, more reliable, more personalized evidence that could meaningfully guide their care, but will never have that opportunity. I'm tremendously proud of the extraordinarily small contribution that I was able to help Weaves in his situation, but I'm also a bit saddened that the 36 hours we spent together for this one decision doesn't yet scale to medical practice, where the average oncologist sees more than 50 patients a week. And yet I'm more optimistic than ever before that OHDSI has a chance to be a real part of the solution to this problem. You know, there's over 1,400 active ingredients and more than 4,000 distinct surgical procedures. So that's like almost 6,000 medical interventions going on every day in the world. And there's also more than 11,000 different conditions, each representing outcomes that a patient may care about. So that's over 63 million intervention outcome pairs. And for each and every one of those, there are many questions that a patient could reasonably ask, whether it be a characterization question, like how often does this happen? A population level estimation question, like does this intervention cause the outcome? Or a patient level prediction question, like what's my risk? And this ocean of unanswered questions isn't going to be answered by each of us going it alone, answering one question at a time, applying one analysis to one database. It's like grabbing a bucket of water back and forth from the shore to try to drain the Atlantic. Instead, we need to think about what we can do together as a community, how we can go about generating evidence at scale, how we can collaborate together to develop analytic solutions that can generate evidence for classes of problems across all interventions and all outcomes, applied to all populations of interest across our entire data network. We need to take on these systemic challenges with the same urgency that all of us would bring if we were sitting at the point of care thinking about our health and the health of our loved ones. So I hope all of you take stock of Jamie's story, think about the story of you and those around you, and think about how all of us can make a difference to bring more reliable evidence to improve better care.